It's my great privilege and honor to welcome you to this Wednesday webinar being done under the auspices of Indian College of Anesthesiologists. This is a hallmark of Indian College of Anesthesiologists, which has been initiated during the COVID pandemic and is carrying on. And we have done 206 webinars, and today is the 207th webinar under the banner of ICA, that is the Indian College of Anesthesiologists. These webinars have become very popular and most looked after. People look for these webinars because of its high scientific content and academic discussion. Today we'll be talking about bleeding in cardiac surgery. Before that, I would like to make a few announcements. One is that the 4th anniversary of Wednesday webinars falls on the 24th of July, that is 24th of this month, which means that we would have finished 4 years and we'll be beginning the 5th year of ICA webinars on that day. Please join us for interesting topics. The next announcement is about the PG Assembly in New Delhi being done under the auspices of ICA from 27 July to 31st July at the GP Pant Hospital. The third important event is the ICA Con 2024 being held at Lucknow, the second weekend of September. Going to be a high quality conference. Please join us. And general instructions to the audience is please put your comments and questions in the chat box. We will address all the questions as far as the time permits. At the end of all the 4 talks, there are 4 top talks. And today's subject, as already mentioned, is the bleeding in cardiac surgery. I have 4, that includes me also. Actually, I have 3 prominent national faculty, including me, it will be 4. One is Dr. Sanjay OP. He is a consultant, senior consultant at Narayana Hrudayalaya. He manages the adult cardiac surgical unit, extremely experienced and valued for his management of patients. And second panelist, moderator, is Dr. Ratan Gupta, who is again working with us for a long time. He's a senior consultant, cardiovascular critical care intensivist. Again, very well experienced and knowledgeable. Then we have Pooja Natarajan, who is currently working in Muddanahalli Satyasai Institute at close to North Bangalore. She's again a consultant and very well read and experienced in coagulation management. And lastly, I'll be with you throughout the course of this event. I request all the speakers to stick to the time limits and then stay till the end of the session today, so that if there are any questions, the questions will be directed to one or more of the speakers, and the panelists are requested to join us during the discussion to make it lively, interesting, and add value to the meeting. With this, I request Dr. Sanjay OP, who is my colleague in Narayana Hrudayalaya, that is Narayana Institute of Cardiac Sciences, to take over and introduce the first speaker so that we get going. Thank you so much. Looking forward to the presentations.
Good evening, everybody. Today, I am going to speak about physiology and pharmacology of clotting. Myself, I am Dr. Siddharth Raju, Associate Consultant, Narayana Hrudayalaya. How clotting or thrombosis happens? It was initially explained by Rodolphe Virchow. It is based on circulatory stasis, endothelial injury, and hypercoagulable state. All three triads together help in thrombosis formation. Then this thrombosis is in turn helped by platelets, endothelium, and coagulation proteins. So thrombosis and anticoagulation run hand in hand within the vascular system, which are so they have a delicate balance. So that helps the blood to be kept in a fluid state and undergo clotting when required and undergo thinning when required, which is again thrombosis is by formation of thrombin and then fibrin production and fibrin strands and clot formation. Antithrombotic mechanism is by thrombomodulin complex, which activates protein C and S, and fibrinolysis by tissue plasminogen activator by plasmin. How it starts? It's injury to the vessel, activation of platelets, formation followed by activation of coagulation pathway with ultimate generation of thrombin and fibrin clot stabilizing the platelet plug. Then further, either it goes to fibrinolysis and clot removal or control of clot extension by antithrombotic mechanism or healing and repair injury. These are the factors, factor 1 to 13, except factor 6, which is removed. And out of this, factor 2, factor 7, factor 9, and factor 10 are vitamin K dependent. Other than this, you have high molecular weight kininogen and precalcin. So procoagulant and anticoagulant, how does it happen? The endothelium secretes both of them. Wall Miliband factor, thrombin when in combination with thrombomodulin activates acts on thrombin activable fibrinolytic inhibitor, inhibits the fibrinolytic inhibitor part and activates that, which in turn prevents fibrinolysis, so promoting clotting. Similarly, plasminogen activator inhibitor, which promotes clotting. And how the anticoagulant happens? By secreting inhibitors like tissue factor pathway inhibitor and tissue plasminogen activator and prostacyclin, and thrombin and thrombomodulin complex activating protein C, which in turn activates protein S and heparin-like materials. Hemostasis, how does it start? Primary and secondary. Primary is by vasoconstriction formed by platelet plug formation. Second is by coagulation and organization of clot. So vasoconstriction, as you can see, as soon as there is vasoconstriction in the vessel, okay, and this leads to reduction in the bleeding slightly. Then you have the platelet aggregation, first platelet adhesion, shape change, granule release, ADP and thromboxanate, and recruitment and aggregation leading to temporary hemostatic plug. Then comes the activation of coagulation factors, that is the intrinsic pathway or the extrinsic pathway. Intrinsic pathway, when the endothelium surface is negatively charged, it activates factor 12. In turn, it will be 11, then followed by 9, 8, 10, and factor 2 and fibrin. Similarly, extrinsic pathway, tissue factor in combination with activated factor 7 activates factor 10 directly, bypassing all these factors, leading to thrombin activation, which in turn activates fibrinogen. So outline, how does it go? Coagulation cascade. First, usually blood exhibits laminar flow in an intact vessel, which always laminar flow prevents clotting. Next, platelets become activated as soon as this endothelium is breached, and then it leads to platelets in turn activate platelets. One by von Willebrand factor binds to G2B and G3 in receptors and causes platelet adhesion. At the same time, thromboxane A2 activates G2B receptors, allowing them to bind to fibrinogen. So hence thromboxane A2 recruits more platelets, more and more platelets, and platelet binds to fibrin, and platelet binds to platelets also and forms temporary hemostatic plug. Then thrombin production happens. Once thrombin is produced by activation of tissue factor and factor 7A, this thrombin also activates the platelets. As a result of this propagation phase, thrombin produces enough fibrin for the clot by intrinsic pathway because the endothelium also has lost its negative charge. Then how the anti-clotting mechanisms happen? What are the factors affecting it? The body has numerous methods. First is inhibit platelet aggregation, block formation of thrombin, inactivate thrombin after it has formed. Remove clots by producing plasmin to destroy fibrin. So basically, PGI2 and nitric oxide both inhibit platelet aggregation. Then the tissue factor pathway inhibitor binds and inhibits the tissue factor 7A complex and prevents extrinsic pathway from forming thrombin. Thrombomodulin inactivates thrombin and allows thrombin to activate protein C, which then binds to protein S, which deactivate factor 5 and factor 8. Then this is the diagrammatic representation of how protein C and S inactivate factor 8 and factor 5. Then antithrombin in the presence of heparin inactivates thrombin and factors 9 and 10. Tissue plasminogen activator secreted by the endothelium and urokinase secreted by the plasmin destroys the fibrin. So this plasmin causes fibrinolysis and resolves the clot. So ultimate main player is the thrombin. Everything revolves around thrombin. So everything ultimately leads to formation of thrombin. This thrombin in turn activates the inhibitory factors of clotting, as well as it activates the platelets, it activates factor 8 and all these things. So thrombin is the main. After thrombin, it is a fibrinogen and then fibrin polymer and clot along with factor 30A. Then what does the coagulation factor inhibitors? Tissue factor pathway inhibitor, as I told, protein C, S, and antithrombin. Then drugs affecting coagulation. Antiplatelets, that is, you can see COX inhibitors, glycoprotein 2B3A receptor antagonist, that is tirofiban, eptifibatide, abciximab, then glycoprotein 2B3A inhibitors, clopidogrel, prasugrel, and ticagrelor. Then phosphodiesterase 3 inhibitors. They all inhibit platelets. So what are the antiplatelet dosing? This is the platelet. The commonest use is aspirin, which is used as 81 mg once daily, and loading dose in MI and all, we use 325 mg loading dose. Okay, and even COX inhibitors also have antiplatelet effect. And also you have clopidogrel, which is ADP receptor antagonist, okay, which prevent platelet aggregation. Ticagrelor also, tirofiban. As you can see, most of them are reversed by DDAVP and platelet transfusion. What are the recommendations? Aspirin low dose can be continued in most of the high-risk surgeries, but the high dose at least 5 days. And clopidogrel at least 5 days has to be stopped. Ticagrelor at least 7 days. Okay. Then clotting factors. What are the anticoagulants? Okay. How do they act? There are 1, 2, 3 color codes. That is orange, bright red, and dark red. Orange means these are the drugs which have multiple targets. That is vitamin K antagonists, which act on factor 7A. Okay. And they act on tinase complex, prothrombinase complex. Tinase complex is nothing but 9A and 8A complex. Prothrombinase complex is 9A, 8A, and 10A. And next is we come to the bright red, which is factor 10A inhibitors, apixaban, edoxaban, fondaparinux, and rivaroxaban, which act on prothrombinase complex. Okay. And dabigatran, which is factor 2 inhibitors, that is thrombin inhibitors, that is dabigatran, bivalirudin, and adactroban. They act directly on factor 2 and inhibit. What are the dosing? These are the dosings: warfarin 2 to 5 and fractionated as I have told you, 18 units the bolus followed by 18 international units and all these things. And enoxaparin is 1 mg per kg, 12th hourly. Similarly, these are the direct thrombin inhibitors and 10 inhibitors. The only hallmark is they don't have antidote. Recommendations is warfarin at least 5 days. These are the recommendations. Fondaparinux is 48 hours and Biolodin is at least 4 hours and unfractionated heparin at least 6 hours before high-risk surgery. These are the blood components where packed red cells are transfused when what products are transfused. PRVCs are transfused when the transfusion trigger kept is at 9 HB hemoglobin or hematocrit of 27. Platelets are transfused at transfusion trigger are transfused when the platelet count is less than 1 lakh for high-risk surgeries and 50,000 for low and medium risk surgeries. And even single donor platelets, it's the same. And one of the important things is single donor platelets raise the platelet by 30 to 40,000. Fresh fusion plasma is given when the INR is more than 1.5. Cryoprecipitate is given when the fibrinogen is less than 150. Basically, fibrinogen increases factor 8 and FFP increases factors by 20%. And here, important point is FFP must be ABO compatible and even PRVCs should be ABO compatible. ABO identical platelet are components of choice except in emergency. Cryoprecipitate can be given across ABO barrier. Factor 7. Factor 7 is approved for usage, isolated combinant factor 7. These are the indications: hemophilia and clotting defects, emergency bleeds, and oral anticoagulant induced hemorrhage in surgery. This is the management used by AFMC Pune in one of their articles of 2009, where initially whatever bleeding happened, initially they are all corrected by giving blood products. In spite of that, if still bleeding is there, then they go for factor 7. Factor 7, it's given 100 mics per kg initially, then repeated after 20 minutes. Then prothrombin complex concentrate. This is the composition of prothrombin complex concentrate, where it comes as a 500 international units vial, which is later diluted and given. And another is 1000 units vial. Okay. Then after dilution, these are the concentrations. Okay. And the heat contains factor 2, 7, 9, 10 in protein C and protein S. One advantage of this is it can be stored at 25 degrees, no need to freeze, and it has a shelf life of 3 years. Okay. And it is from microbiological point of view, unless the method of opening and reconstruction precludes the risk of microbial contamination, the product should be used immediately. Cost factor is very much costly. Fibrinogen, again, Fibrija, which is used in UK, it comes as 1 gram fibrinogen per bottle. It is diluted to a 50 ml. Then it comes as a powder solvent. What is the difference is consistent fibrinogen content and infusion. No need for freezing and thawing. No need for blood grouping. So after reconstitution, you give it 10 ml per minute to 600 ml per hour, 5 minutes per 1 gram fibrinogen bottle. What is the advantage? The reduction in time to prepare and infuse the required dose. Thank you.
Thank you, Siddharth, for your talk. And over to Pooja to introduce the next speaker.
I think it's
No, Ratan, sorry. Over to
Hi.
Ratan.
Hi, Sanjay.
Hi.
That was a nice talk, Siddharth. I would like to invite Dr. Sunil. He is working as an associate consultant. The slide, please. Please, can you share Sunil's slide?
Sure, sir, sure.
Yeah. The next slide, please.
Good evening, everyone. I'm
Yeah.
Dr. Sunil Kumar. I'm a cardiac intensivist in Narayana Vidyalaya, Bangalore. I'll be discussing on coagulation monitoring. I have no disclosures to make. So I'll be briefly going through conventional laboratory testing, principles of viscoelastic testing, that is thromboelastography, rotational thromboelastometry, milestones in viscoelastic testing, interpretation, and algorithm-based transfusion of the blood products. Protein coagulation testing. There are many coagulation testing modalities, which include bleeding tests, which test platelet function, thrombin time, which assess factor 1 and 2, prothrombin time, which assess the extrinsic pathway along with the common pathway, that is 1, 2, 5, and 10. Activated partial thromboplastin time, which assesses the intrinsic pathway as well as common pathway. D-dimers, these are the protein fragment when a blood clot dissolves. So this can also be tested. Fibrinogen levels can be measured as well as platelet counts. So all the normal values has been displayed on the right side of the screen. Activated clotting time. The picture where you are seeing the cartridges are filled with the 2 ml of blood and can be placed into the container, which will measure the activated clotting time. In these cartridges, there will be diatomaceous earth or kaolin, which will trigger the clotting pathway. The recent ACT machines have come up, which is automated one, which we are using in our theaters. Compared the advantages of viscoelastic testing compared to the conventional testing. Since the conventional laboratory testing, we need to be separated. Like we have to take out the RBCs, platelet poor plasma. Plasma has to be separated, which take little longer time. It has to be sent to the laboratories, which has a longer turnover time. As compared to viscoelastic testing, it can be used with a blood sample, whole blood sample, and can be used as a point of care testing. The results will be available in minutes. So it's a holistic overview of the ex vivo clotting. This is Dr. Helmut. He developed the tech, the University of Heidelberg, in 1948. This is the body of the literature in viscoelastic testing. So after the development of viscoelastic testing in 1948, the literature has come up rampantly. In 1960s, they started using in Vietnam War. In 1985, they started using in liver transplant, which reduced the administration of blood and fluid volumes. And in 1999, they started using in cardiac surgeries, which again showed beneficial results. Principles of viscoelastic testing. There is a mechanical viscoelastic testing. Here, there will be a cup and a torsion wire with a pin. In TEG, there will be a rotating cup. Then when the clotting will be formed, that will make a picture out of the clotting. Whereas in Rotem, the tip will be rotating compared to the stationary cup. So thereby you'll be getting a trace out of it. The newer ones, that is the resonance viscoelastic testing, this uses, that is type 6, which uses resonance frequency to measure the blood viscoelastic testing. So this is the diagram which comes when you have placed a blood in the TEG machine. So both TEG as well as Rotem has been displayed in this picture. The initial part would be from the TEG, and the later part, that is CT, will be depicting the Rotem. So the R means it's a reaction time. So it is from the initiation to the formation of the clot. The same is in CT. And the K, that is clot kinetics, it's the starting of the clot firmness. CFT, which will be in Rotem. And the angle, that is the kinetics of the clot deployment. So if you put a angle, tangential angle from the K point, which will give the angle. So it gives the speed of thrombin generation, fibrin deposition, as well as clotting, cross linking. You could then the A5, it is the early parameter of the clot strength, and the MA, that is maximum amplitude. This depicts the strength of the clot, that is mainly dependent on the platelets. The initial part is the coagulation part, and the later part is the fibrinolysis part. Here, usually the clot lysis after 30 minutes would be seen. So the R time is usually 5 to 8 seconds. Usually it is dependent on coagulation factors. So in this scenario, you will be giving FFPs if the clot R time is more than 8. K time, if it is less than 3, is normal. If it is more than 3, then you have to give cryoprecipitate to supplement fibrinogen. The angle, the normal value is 45 to 37. If it is more than 75, we have to supplement with cryo and platelets. Maximum amplitude, now 55 to 75, where we have to, if it is less than 55, we have to supplement with platelets. And fibrinolysis, if it is less than 8, it is normal. If it is more, it might be hypercoagulable state. Let's discuss regarding hypocoagulation state. The clot initiation time is increased. That means there is a factor deficiency, which can be represented as a wine glass. And in this scenario, you have to give the clotting factors by giving FFPs. Clot kinetics. If the clot kinetics is reduced, maybe due to hypofibrinogenemia or thrombocytopenia, which can be used as a test, which can be represented as a test tube here. In that scenario, it has to be supplemented with platelets. Then, if the clot strength is reduced, maybe due to hypofibrinogenemia, thrombocytopenia, or factor deficiency, that can be represented as a champagne flute. You can supplement cryo or fibrinogen here. In fibrinolysis, that is due to excessive clot breakdown, the reaction time might be short, normal, or prolonged. The maximum amplitude, it can be continuously decreased or sudden decrease. We usually analyze clot lysis after 30 minutes, which if it is increased, it means to say there is an excessive clot breakdown, which can be represented with inverted martini glass. Here we'll be giving fibrinolysis such as tranexamic acid. In a hypercoagulable state, that is the state where the clot tendency to clot. In this scenario, the clot initiation time is decreased. There will be increased thrombus formation, and there will be hypercoagulable state. It may be due to thrombocytosis, hyperfibrinogenemia. So, and there won't be any kind of, the clot lysis will be less. This suggests early stages of disseminated intravascular coagulation. So in hypofibrinolysis, the reaction time again can be short, normal, or prolonged. But the maximum clot strength is continuous. The clot lysis, which after 30 minutes, which is close to 6. That means to say there is a total fibrinolytic shutdown. There is no inherent property to thrombolyze. So depiction of rotum and the nomenclature. Compared to TEG, the rotum has different nomenclatures, such as extreme. I mean to say, only the extrinsic pathway and the common pathway will be triggered here, and interim can be used to stimulate the intrinsic pathway. Fiftum, where only fibrinogen will be analyzed. Whereas in aptum, we'll be using antifibrinolytic to delineate any effects of antifibrinolytics. So there are certain specialized assays which will analyze the hemostasis. So this is a varieties of rotum assays which have been telling. This is interim, where allergic acid has been in use to initiate the contact pathway. The tissue extreme, where the tissue factor will be activated. And then heparin is, if the patient is on bypass, we need to take out the heparin so that the normal clotting happens. So here we'll be using lipolyzed heparinase. In fiftum, we'll be using cytochalasin D, so that the platelet will be suppressed and only fibrinogen is depicted in the picture. And in for analyzing platelets in rotum, we have there is no test for analysis of platelets in rotum, but we can use Verify Now or platelet function impedance aggregometry. As compared to TEG, it has TEG platelet mapping. Coming to coagulation treatment based upon algorithm by rotum during cardiac surgery. So while rewarming, we need to call someone to take point of care testing samples. Then we should analyze ACT. Then we have to administer protamine, that is less than 1 milligram post CPV, and repeat the ACT again. If it is less, you can administer additional protamine. If still bleeding not stopped, then we can assess 5-minute packing method. That means we put a sponge into the chest cavity, and the sponge weight has been negated. If the blood volume which is being sucked into the sponges. If it is less than 60 gram, then no need of doing any kind of blood products. But if it is more than 60 gram, should analyze the point of care testing. And if the functioning platelet levels are less than 75 or A10 exterm, that is less than 35, or plus A10 FibTem more than 8, you should administer platelets. One pool of platelets should be administered. If A10 FibTem less than 8 mm, you have to supplement with cryoprecipitate or fibrinogen concentrates. If the CT exterm is more than 90 seconds, in this you have to supplement with fresh frozen plasmas. The Cochrane review has done the analysis of TEG as well as ROTAM to monitor the hemostatic treatment in bleeding, both adult and children, which showed mortality benefit in both TEG and ROTAM. As you could see, the diamond which is facing towards, which is favoring the TEG and ROTAM. So these many subjects have been taken into consideration and the study is showing which is favoring TEG and ROTAM. Again, depending upon the coagulation state from mild to severe postoperative blood loss. Even then, these many patients have been taken into consideration, again, which is favoring TEG or ROTAM. So active research are going on in this field of areas such as cardiothoracic surgery, intervention cardiology, trauma, gynecologic and obstetric care, liver disease and transplant, and critical care. To conclude, so there is a growing evidence of that application of TEG or ROTAM guided transfusions may reduce the need of blood products and improving morbidity in patients with bleeding. However, there are primary trials are there have been established with a low evidence. So the way forward is to get a randomized RCTs for evaluation of the TEG and ROTAM guided transfusion in acute settings. Thank you.
That was a nice presentation, Sunil. Now, I would like you to unshare your screen, and I invite Dr. Pooja Natarajan to introduce the next speaker.
It's my pleasure to introduce Dr. Medha Mozumder, who's our dynamic ICU intensivist. On to you, Medha. She'll be talking on hazards of blood transfusion. Medha?
Good evening. Today I will talk about the hazards of blood transfusion. So, like drugs, transfusion has primary and secondary adverse reactions, which can be also divided into immediate or delayed. So the transfusion reaction are classified into two parts: immune origin, non-immune origin. Immune origin are also again divided into immediate and late, and non-immune origin is also divided into immediate and late. So in the immediate transfusion reaction, you will have hemolytic, febrile, non-hemolytic, allergic, and trally. And late transfusion reaction in immune is also again delayed hemolytic reaction, alloimmunization, post-transfusion purpura, and graft versus host disease. Non-immune origin will be immediate. In immediate transfusion is circulatory overload, or basically TACO, bacterial contamination, metabolic complication, which is hypothermia, citrate toxicity, or hyperkalemia. Late transfusion reaction in the non-immune origin would be infections such as bacterial, parasites, or viral, and hemosiderosis. So these is what the acute transfusion reactions are. I'll be talking about each of them separately. Acute hemolytic reaction. So basically, the hemolytic reaction is basically an immune mediated lysis, which is intravascular or extravascular of the transfused red cells. The transfusion of incompatible red cells to the recipient who has previously preformed antibodies to red cell surface antigen causes this problem. The patient, it usually happens when the blood specimen is mismatched or the patient is misidentified. It usually happens within minutes of starting of the transfusion, and the recipient antibodies activates the complement activation, which is why this reaction occurs. Okay. So basically in this picture, we can see that the red cell antigen, which is the green dots here, basically combined with the IgM antibody bodies of the patient and then form this antigen antibody reaction complex, which basically forms the reaction which activates the complement cascade. The complement cascade then, there are two parts of it. The C5b29 causes intravascular hemolysis, which can cause DIC, or it can also cause hemoglobinemia, hemoglobinuria, and raise serum bilirubin. The C3a to C5 and C5a complement causes hypotension and shock. Okay. So basically the clinical signs are shock, hypotension, and bronchospasm, which is basically mediated by complement fragments, anaphylotoxins C3a and C5a, and other mediators of inflammation. It can cause renal ischemia or tubular necrosis, which can result in acute renal failure. The cytokine networks such as IL-1, 6, 8, and TFN alpha can cause fever, hypotension, and leukocytes and coagulation activation. The activation of the coagulation cascade then can cause DIC. So severity also depends upon the amount of blood transfused and the transfusion rate. The faster the infusion rate, more is the severe is the reaction. Okay. Febrile non-hemolytic transfusion reaction basically results in fever due to the pyrogen production of IL-1, 6, TF, and alpha. The definition is basically the rise of 1 degree of temperature in 2 hours without any evidence of hemolysis. It happens in 1 to 3% of the transfusion episode. The antibody directed toward the transfused leukocytes and platelets causes an antigen-antibody reaction pyrogen from the results in the from the plasmocytes. The use of leukocyte-reduced blood component can be done for prevention of this reaction. Allergic reaction. This happens in 1% of transfusion recipients. The cause is again an antigen-antibody reaction. The sensitization is due to the transfused plasma protein. The symptoms result in cutaneous along with nausea, vomiting, diarrhea, and bronchospasm. The cutaneous part can be urticaria, flushing, and itching. It is not really dose related and is generally very mild, is not reoccurrent and responds to antihistamines. It very rarely does it cause anaphylaxis. And usually consider to prevent this, we can use washed blood components or high dose of steroids or antihistamines. Transfusion associated circulatory overload. So basically, transfusion associated circulatory overload occurs when the blood components are administered at a rate greater than the patient's cardiac output. The patient is then unable to compensate for the expanded blood volume, and within 6 to 8 hours post transfusion, this shows signs of orthopnea, dyspnea, pulmonary edema, hypertension, and tachycardia. The treatment for this is basically to stop transfusion, give oxygen, diuretics, and other heart failure management. If the patient is very serious, then the ventilatory support can also be considered. Transfusion related acute lung injury. So basically, it is a non-cardiogenic pulmonary edema. The incidence is about 0.08 to 15%. It basically follows a two-hit model. The two-hit model basically is that the first hit is generally happens for a transfusion happens because of the underlying condition of the patient. And the second hit happens because of the antibodies and the factors transferred to the recipient during the transfusion. Now, during the first hit, as I said, it is because of the underlying patient factors, resulting in activation of the pulmonary endothelium, accumulation and adherence of the prime neutrophils in the lungs. Now, the second hit happens because of the activation of the endothelium, the neutrophil mediators in the transfused blood, which results in the capillary leakage and pulmonary edema. The second hit can be either antibody mediated or it can be non-antibody mediated. Now, the antibody mediated means that there is a passive transfer of the HLA antibody or the anti-leukocyte antibody. And non-antibody mediated means there is an accumulation of the pro-inflammatory mediators already during storage. Now, so this is basically the concept of the first hit, where this is the picture showing the problems with the alveoli, where there is already a macrophage present and there is fibroblast present, and there is already a neutrophil present in the basement in the capillary. And this is the second part of the picture, which is on the right hand side, would be when there is the second hit, where you can see the migrating neutrophil from the capillary and the leaky capillary. You can see the alveolar macrophage, which has then released the inflammatory components IL-1, 6, IL-8, as well as the activated neutrophil, which is again given out other complexes. Okay. Now, Charlie is basically when there are definitions of Charlie is basically divided into three parts: suspected Charlie, possible Charlie, and delayed Charlie. Now, suspected Charlie is when there is an acute onset within 6 hours of blood transfusion, with PaO2 to FiO2 ratio being less than 300, or worsening of P to F ratio, bilateral infiltrate changes in the chest radiograph, and no signs of any hydrostatic pulmonary edema, or no other risk factor for acute lung injury. There's something called possible Charlie, which is the same as suspected Charlie, but there's another risk factor present for acute lung injury. Now, in the latest classification, this possible Charlie is not there, and Charlie has been separated into two parts, which is basically Charlie 1 and Charlie 2, which basically is Charlie 1 being the same as a suspected Charlie without any ARDS component, and Charlie 2, which is basically suspected Charlie with ARDS component as a risk factor. And delayed Charlie is basically the same as the suspected Charlie, with the onset being after 6 to 72 hours of blood transfusion. Okay, so what do we see in Charlie? We see respiratory distress, hypoxia, fever, bilateral pulmonary edema during or within 6 hours of a transfusion. Patients are at risk. Who are at risk are usually people who have undergone cardiac surgery and sepsis or have massive blood transfusion. We can only give supportive treatment for Charlie. Resolution generally happens in 48 to 96 hours. However, the mortality can be as high as 10%. So to prevent this, we can actually give leukocyte reduced components, and for diagnosing it, we can actually see for HLA and leukocyte antibody in donor plasma and HLA antigen typing in the recipient. Hypertensive reaction. After platelet transfusion or RBCs, the bradykinin generation occurs because of the contact of the plasma to the artificial surface, which results in vasodilation and hypotension. So to prevent this, you can stop the transfusion, which results in rapid resolution of this hypertensive reaction. It is seen in patients more who have been treated with ACE inhibitors. Metabolic complications. Metabolic complications are of two types. One is citrate toxicity and hyperkalemia. So citrate toxicity happens because the calcium binds to the citrate preservative in the blood or blood components of which are being transfused. So hypocalcemia can cause cardiac depression. Now, in citrate metabolism, most of it happens by liver in hepatic patients, or so patients who have hepatic disease or dysfunction of the liver or are hypothermic may demonstrate hypocalcemia features and may require calcium transfusion. Now, citrate, which binds to the calcium in the preservative, basically prevents the calcium from interacting with the coagulation system. So this results in so it can also cause bleeding. The symptoms are basically arrhythmia because of hypocalcemia, can have severe hypotension because of the cardiac depression which happens, and increase in CVP. The treatment is basically supplement of calcium gluconate or chloride, optimizing liver function and cardiac output, and RRT if required for correction of metabolic acidosis, which happens because of this. Hyperkalemia. The extracellular concentration of potassium stored in the blood steadily increases with time. So the amount of extracellular potassium transfused with each unit is typically less than 4 milliequal per unit. However, if a large transfusion is given, naturally the amount of potassium in the person goes up. So chances of hyperkalemia is very high. So one has to be careful. To prevent this, you can use washed blood cells or use blood which is less than 7 days old. Delayed transfusion reaction. These are the things I will be discussing about. Okay, so delayed hemolytic reaction. This basically happens about the induction. Causes are basically induction of antibody days or weeks after a transfusion by the transfused red cells. This basically has it can happen between 24 hours to 30 days post transfusion. The appearance days after transfusion is basically an anamnestic response. So with each transfusion for any patient, there is 1 to 1.6%, 1 to 1.6% risk of sensitizing a recipient to a red cell antigen. Now, most of the time, the delayed hemolytic reaction has extravascular hemolysis. So symptoms are less severe than acute hemolytic reaction because as there is no complement activation, the clinical features are generally fever, malaise, and fatigue and jaundice. There's a positive Coombs test which occurs, and there's a regenerative anemia and indirect hyperimmunemia occurs with increased LDH, decreased hepatoglobin, and rarely hemoglobinemia. Okay, the implicated antibodies in a delayed hemolytic reactions are Duffy and KID. Less intense complement activation, delayed reaction, sometimes also seen in ABO incompatibility. We can prevent it by giving a high dose of IVIG 400 mg per kg to the patient. Now, what is the difference between a intravascular and extravascular hemolysis? In intravascular hemolysis, as you will have hemoglobinemia, hemoglobinuria, urinary hemosiderin, methemoglobinemia, and the morphology will show you cystocytes, spherocytes, and agglutination. Whereas in extracellular vascularization, extravascular hemolysis, you will not see any of this. Only there will be a rise of bilirubin and LDH. So, and in morphology wise, it will show spherocytes, elliptocytes, and ovulocytes. Okay. Now, acute versus delayed hemolytic reaction. In acute type, both are immune origin. But in acute type, the signs and symptoms will be fever, chills, anxiety, shock, dyspnea, oliguria. Usually causes EBO incompatibility or other complement can also take a part in it. The treatment is basically stop transfusion, hydrate, support blood pressure, respiration, induce diuresis, treat shock and DIC if present. To prevent this, you can ensure proper sample and recipient identification. For delayed one, you will see fever, malaise, indirect hyperbilirubinemia, increased LDH and urobilinogen, and falling crit. Usually by the IgG non-complement fixing antibodies such as anti-RES and anti-KEL. For treatment, you have to monitor the crit, renal and hepatic function, coagulation profile, and no acute treatment is required generally. We have to just review for preventing, we have to just review the historical records, ensure proper identification, and give antigen negative units if possible, and high dose of IVIG if required. Okay. Post transfusion purpura. Thrombocytopenia, which occurs in 1 to 3 weeks after transfusion, is basically caused post-transfusion purpura. It basically it is a potentially fatal thrombocytopenia followed by blood or platelet transfusion. It develops from the platelet alloantibody, which basically destroys the patient's own platelets. Basically the platelet count reduces within 5 to 10 days following transfusion, and what you basically see is the platelet specific antigen, which is HPA-IA, found on the platelet glycoprotein 3A receptor. Now, this is the antibody, the detection, which is there as a diagnostic factor. Spontaneous resolution happens after 2-3 weeks, and the treatment is adapted to risk for hemorrhage. So if it's low risk, then wait and see. If it is high risk, then plasmapheresis, platelet transfusion, and IV to be given. Graft versus host disease. So transfusion of immunocompetent lymphocytes to immunodeficient recipient, or transfusion of blood products from HLA homozygous donor to immunodeficient HLA heterozygous recipients cause this graft versus host disease. The donor lymphocytes engraft and recognize the host in histocompatibility antigen and attack the host tissues. It basically attacks the skin, bone marrow, and the GI system. So that in the clinical features, we will see fever, cutaneous rash, diarrhea, hepatitis, and marrow aplasia. In incidence is usually 0.1 to 1%. Mortality is 80 to 90%. It is fatal in most cases, as I said earlier. Prevention is irradiation of blood and cellular components to inactivate lymphocytes. This graft versus host disease generally starts between 2 to 30 days of the transfusion. It says 10 to 12 days, but it has also been seen to start between 2 days of the transfusion. Hemosiderosis. It basically happens to patients who usually get repeated blood transfusion. So basically in each unit of packed RBC, we have 150 to 250 mg of iron. This iron accumulation, which happens to repeated blood transfusion, can cause organ damage like the heart, liver, or pancreatic islet cell. Treatment is basically parenteral deferoxamine or enteral deferoxyrox or chelation. Transfusion transmitted disease. So basically, allogenic blood donation is tested for HbA surface antigen, HB core antigen, hepatitis C antigen, HIV antigen P24, human T lymphotrophic virus 1, syphilis, and HIV 1 and 2 type. Now, method is basically serologic with NAT. The residual risk which is there in the window period for these are basically that when in this situation, the donors can give the blood to the recipients and the recipient will receive it. But because the donor's blood, the transmitted disease is in the window period, that's why even though the donor's blood is infectious, the assay may not detect it. So that is one of the risks which happens. In HIV, it is seen 12 days here. However, if we do nucleic acid testing, the window period drops down to 9 to 10 days. Out of this, the most serious would be the HCV virus, which is basically progresses to chronic hepatitis to cirrhosis in 20% of the patient, and 5% goes to hepatocellular carcinoma. Thank you.
Thank you, Medha, for the lovely presentation. On to Muralidhar sir now.
Thank you, Dr. Pooja, for being with us, and thank you, Medha, for that excellent talk. Now we go on to the last talk of the day. This is about blood conservation in cardiac surgery. For this, I will invite Dr. Girish, who is a consultant intensivist in our setting, manages cardiac surgical patients on a routine basis, and I request Dr. Girish to start his presentation. Thank
Good
you.
evening, everyone. Myself, Dr. Girish. I'm an associate consultant in first floor EITU. I'll be talking about what are our blood conservation strategies. I do not have any disclosures to make. And why blood conservation is important is it's to minimize the allogenic blood transfusion, which are associated with various risks such as transfusion reaction, infections, and other immunological complications. But is transfusion really that important? There's a study which was conducted on Jehovah's Witness versus transfused patients. A total of 322 patients were witnesses were employed, and 87,453 non-witnesses underwent cardiac surgery were enrolled for a period of 1983 to 2011. As you can see, there is a very large study comparing the non-trans witness patient, and the witnesses conclusion was witnesses do not appear to be at increased risk for surgical complications or long-term mortality compared to when comparisons are properly made by transfusion status. So Jehovah's Witness who do not receive blood transfusion, the moderate risk or complication, they are not at higher risk. So let's look at what is the recent update, 2021 update given by Society of Thoracic Surgery, Cardiovascular Anesthesia update on patient blood management. I'll be talking about the key takeaways of this. The first key takeaway of that was use of tranexamic acid or epsilon amino caproic acid reduce blood loss and transfusion and are indicated in cardiac surgery. So this is a class 1 level A evidence, and all this key takeaways, all these recommendations are based on randomized control trial, newer studies and everything. So there is a attacker study which includes aspirin and tranexamic acid, but we'll be looking at only tranexamic acid cohort, and they have included 31 sites, 7 countries, a large study of 4,631 patients. They've compared tranexamic acid with placebo, and their primary outcome was composite death and thrombotic events. Initially, they used to give a dose of 100 milligram per kg, but they noticed seizures in patients, so they've reduced the dose to 50 milligram per kg. And it was published in New England Journal of Medicine. So as you can see, what I've marked, the re-exploration, total products, and mechanical ventilation Rs were statistically significant in patients who received tranexamic acid compared to patients who did not receive tranexamic acid. So this is why they are given as a class 1 level A evidence. I can see in the tranexamic acid 15 patients had seizure activities. After the reduction of dose, the seizure activity has come down. So next key takeaway from their update is in patients undergoing cardiac surgery, a restrictive preoperative allogenic RBC transfusion strategy is recommended in preference to a liberal transfusion strategy for preoperative blood conservation, as it reduces transfusion rate and units of allogenic RBCs without increased risk of mortality and morbidity. So basically, they say that restrictive transfusion strategy is recommended compared to a liberal strategy. How do they back it up? So that is when you consider restrictive to liberal transfusion, or when you withhold PCs or give PCs, our main dilemma would be not giving hemoglobin would mean tissue hypoxemia. Giving hemoglobin transfusion would lead to RBC, would lead to allogenic. So we need what level of anemia is said and what is the clinical transfusion trigger is what the dilemma usually comes. What they say is that it has to be individualized and institutionalized based on the blood availability and other things. So there have been several randomized control trial which includes 8,000 patients from 4 countries. They have where all the RCT studies have a restrictive trigger of 7 to 8 and a liberal trigger transfusion trigger of 8 to 10. So with restrictive there is more anemia, with liberal trigger there is more transfusion, and obviously there is 30% reduction in RBC transfusion with restrictive measures. So this meta-analysis of all these things show no difference in mortality compared to restrictive or liberal or reoperations or MI or stroke. When I talk about, there are two major trials which happened on this: transfusion indication threshold reduction titer 2 trial and transfusion recommendation in cardiac TRICS trial. This was the titer 2 trial was done in 2015. This was done in 2017. Titer 2 trial had 2,107 patients and TRICS had 5,000 patients. So both were similar and comparable, but only difference that is that the primary outcome did not change, the re-examination did not change, but the mortality in titer 2 trial was for liberal patients was 1.6% higher. That is, in liberal there was 4.2, and in restrictive transfusion status was 2.6. There was 1.6% more mortality in liberal transfusion strategies. So now, how to correct the preoperative anemia? Preoperative erythropoietin administration in cardiac has shown a substantial reduction in the allogenic blood transfusion, but the problem is having thrombotic events and promotion of tumor growth. The guidelines recommended using a brief EPO erythropoietin with iron in patients having risk of post-operative, and in those who refuse transfusion, example Jehovah's Witness, it is a class 2A level B evidence. And preoperative autologous donation candidates may also benefit from erythropoietin, which is a class 2B level A evidence. So what is preoperative autologous donation? A repeated blood donation for approximately 450 ml, which begins 5 weeks preceding surgery. So we stop it before 48 to 72 hours to equilibrate the blood volume. The major advantage is it reduces viral transmission, immune-mediated hemolysis, allergic reaction. But the problem what they have noted is that 50% of the pre-donated blood is unused. And for a heart patient who cyanotic heart disease or cardiac surgery with aortic stenosis, these could be contraindication, but can be useful in patients where the uncommon blood types and having cross-matching difficulties can be used. So the preoperative anemia management, there's a large study which includes all types of surgery, include cardiac surgery. They've given a guidelines for how much hemoglobin is appropriate, safety and effective patient blood management program, surgical patient. They said that if it is an elective surgery and if the hemoglobin is less than 10, if it is surgery in more than 5 days, if it is more than 10, you can go for surgery. If it is less than 10, and if the anemia is noted, and the most common type of anemia in cardiac patient is some iron deficiency anemia. If there is iron deficiency anemia, give supplements erythropoietin and can be taken off for surgery. If the hemoglobin, the iron deficiency is unlikely and there has to be workup be done by the hematology team, then that workup has to be done. If it is an emergency surgery, then directly can go for surgery. So autologous blood transfusion, there is a study conducted on aortic dissection which showed that there is decreased blood consumption. They've included 497 patients, and as you can see, autologous blood transfusion, the number of blood transfusion induced is 9. Renal failure is 5.6%, and post-operative days is also reduced. So autologous blood transfusion has been studied in aortic dissection and can be used as a safe method. So what are the recommendations of anticoagulants and antiplatelet stopping? For dabigatran, it's a thrombin inhibitor and factor 10 inhibitor. If it is an emergency surgery, then you can reverse it with their antidote, idarcuzumab and andaxantant alpha. And if that is not available, you can use prothrombin complex concentrate, which is a class 2A level C LD evidence. And other TKW was antiplatelet stopping, which is a class 1 level B evidence. Ticagrelor should be withdrawn preoperatively minimum of 3 days. clopidogrel should be withdrawn minimum of 5 days and prasugrel for 7 days. There's a groundbreaking trial which was done on, which is called Target Cabbage trial, which they have included a point of care testing, tag rotem. So they say that between the clopidogrel naive and treated dose, the overall outcome did not change. But the main study purpose of this was whether you can use point of care testing to estimate the risk of bleeding in patients. So they've included MAD, maximum amplitude ADP, more than 50. You can do the surgery within a day. ADP of 35 to 40, 3 to 5 days, and maximum amplitude less than 35, you have to wait for more than 5 days. So point of care testing has been used in this and preoperatively, and based on that, you can take up for surgery. And this is one more child is the drain output. The darker shade one where the clopidogrel has been stopped for 5 days and the drain output is less. As it is continued, the drain output has have a similar picture. So continuing clopidogrel, not continuing clopidogrel will not change much the drain output, but point of care testing will be beneficial in estimating the patient for taking up for surgery. So next is a goal-directed transfusion algorithm which incorporate point-of-care testing such as viscoelectric devices are recommended to reduce pre-procedural bleeding and transfusion cardiac surgical patient. So point-of-care TEG, ROTEM, contra, all this can be used. It's a class 1 level BR evidence. I will not talk much about this as it's already been covered. So this is a study which many studies which they have taken where the point of care algorithm is compared with the laboratory testing. As you can see, all the diamonds fall into the point of care testing. It was published in 2015 in Corridor by Corridor et al. And it shows that point of care testing is much beneficial. And next is a harm level evidence where prophylactic use of plasma in cardiac operation in the absence of coagulopathy is not indicated. As long as there is no laboratory investigations of coagulopathy and bleeding, there is no need for transfusing plasma. These are next are very basic recommendations. Reduced priming volume in the CPB circuit, reduced hemodilation, and is not indicated blood conservation. And as you can see, Sun et al. In 2017 has done 47 patients where increased priming volume, their transfusions were more, and also which was supported by Dickinson in 2019 where 21,000 patients has similar results. And next is routine use of cell salvage. It was a 2011 guidance that they have continued. Class 1 level evidence, they have not changed that. They did not argue on that. The principle basically, blood is collected as an aspiration directly from the surgical site, blood surgical swabs, and it is combined with anticoagulant, then filtered, and with an high hematocrit after washing, it is given back after high-speed centrifugation. This is a pictorial representation of how it works. Then all these things are collected, it is taken, and saline wash is given, centrifuged, the waste is discarded, and blood is collected in a refuse bag and given back to the patient. Next recommendation was that allogenic RBC transfusion is unlikely to improve oxygen transport when the hemoglobin concentration is greater than 10. So 10/30 rule, that hemoglobin of 10 and hematocrit of 30. Beyond that, if you increase the hemoglobin, you'll be wasting the PRBC transfusion because it will be unlikely to improve the oxygen transport. Next recommendation was minimally invasive extracorporeal circulation is reasonable to reduce blood loss and red cell transfusion as part of combined conversion approach. So what is minimally invasive extracorporeal circuit? It is kind of an ECMO where the tubings are smaller and it is a closed circuit which prevents elimination of blood air interaction. So reduces surge response. Because the tubings are very smaller, the hemodilution is less, it is biocompatible, and lack of scavenging cell salvage is not with this. This is a study. Basically, it is usually employed in isolated CABGs, isolated valve cases, but they have not done a very big study. And there is a study which is compared conventional versus miniature, and to compare that, they have included 2,196 and 2,154, and it significantly reduces the composite mortality, stroke, and renal myocardial infarction compared to a conventional CPB. So my takeaway points would be at the end, manage anemia, optimize coagulation, and an interdisciplinary blood consumption modalities and patient-centered decision making in order to achieve improved patient outcomes. Thank you.
Thank you, Dr. Girish, for that excellent presentation on blood conservation. You have given important take points, and I should congratulate you for that excellent presentation. And now the panel is open. Comments, questions are welcome. And I request you to unshare the screen, and all the panelists must switch on their videos, please. Please unshare the screen. Comments, questions are welcome. Many questions are there in chat box. We're waiting for questions to come up. I just wanted to make one comment that the 10 by 30 rules looks appropriate, but in patients who are on ECMO, these rules may be slightly modified. For example, people who are on venous ECMO, we need to have a higher hematocrit, around 12 to 14 is recommended. So that has to be kept in mind. Dr. Sanjay and Ratan, your comments?
Yeah, I think it was excellent presentations. A lot of take homes. One question I have for Dr. Sunil. When you're doing ROTEM, what ROTEM to ask in a patient who is in the intensive care and is bleeding post-operative? So how to go about it, Sunil? Whether to ask XTEM or INTEM or FIBTEM? How to decide on that? Or should we ask for everything?
So based upon the history, if the patient has trauma, we'll be trying to
This
ask
is
for
the post-operative cardiac surgery patient who's bleeding.
Okay. So in that scenario, you can think in terms of asking FIBTEM. INTEM, as well as if we want platelet and ask platelet aggregometry test.
Okay. All right. So if there are any coagulation factor deficiencies, you will probably have to get a INTEM or XTEM as well. If you're suspecting, I think platelet dysfunction, yes, you're right. You can ask for the aggregate test and right. Yeah.
Sanjay, your comments? Any comments you want to make?
Yeah, I think a platelet aggregation tech is something you can consider when you have a platelet count which is showing as low, and in case your blood bank is actually running out of products. If the platelet aggregation tech shows a good functionality of the platelet, then I don't think increasing the platelet number per se is going to improve the clotting. So that's where it comes in. Second point is, this is where I think ROTEM loses out to a tech, because a tech is something which is going to give you everything in one shot. Whereas in a ROTEM, you will have to pick and choose what you want to do, and then try to corroborate all the evidences put together before you can actually reach a substantial diagnosis. But I think, there are lots of other factors to it. But that's where a tech is found to be much more user-friendly than a router.
Thank you for that. There are a couple of questions on the chat box. We'll go through that. First one is, what is the effect of red cell mass on clotting? Who will take this question? I think it's a physiology-based question. Can I ask Siddharth to reply to this question? What is the effect of red cell mass on clotting?
Yes, in the secondary hemostasis part, it helps. Red cell mass does play a role in formation of clotting. Clotting is formed in layers. In pathology, they describe in the microscopically the lines of Zahn, where a layer of platelet followed by layer of RBCs. So red cell mass just play a role in clotting. So if the patient is hemodilated, clot strength won't be good. So we need a good red cell mass. I agree with. I would like to put that through like that.
Right. Next question is about the use of antifibrinolytics in your center. So what is the antifibrinolytic you use in your center? That is a question. Okay, this can be answered by anyone who is in the either speakers or panelists, both can answer. Maybe one speaker and one panelist.
We usually use tranexamic acid in our center, and we usually give a stat of 1 gram followed by infusion. We give it. So basically, while giving infusion, we monitor how the bleeding is faring clinically also. At the same time, we send a coagulation profile. If required, we repeat, do a TEG in a baseline and repeat the TEG. Is really the tranexamic acid infusion helping? We follow up.
Yeah, I totally agree with you. We use tranexamic acid more commonly than any of the other antifibrinolytic agents. The dose is why we use in theater is 10 milligram per kg bolus followed by 1 milligram per kg per hour infusion till the end of surgery. Unless the patient is continuously bleeding, where you may continue the infusion in the post-operative period. The dosage is a bit variable. Some people recommend anywhere from 20 to 50 milligram per kg bolus for tranexamic acid. But the problem is, higher the dose, the higher is the risk of seizures. So I think your safe bet is to use anywhere from 10 to 25 milligrams per kg bolus followed by infusion of 1 to 5 milligram per kg per hour. That's what we know. I use 10 milligram per kg bolus followed by 1 milligram per kg per hour. Any of the panelists want to add anything to that? Ratan, how will you use tranexamic acid?
And not on a routine basis, I think, but whenever you have a high-risk patient for bleeding, especially patients who are coming with risk factors like reoperation or very major surgical procedures where extensive surgery is involved, like a dissection, arch involvement. I think those kind of patients, probably you can give it as a prophylactic this thing. Otherwise, I think we generally, especially coronaries, we generally try to avoid it. We were worried about the graft. Valve surgeries, probably people are a little more generous, especially re-surgeries.
Yeah. Actually, you can also go by TEG when there's evidence of lysis, clot lysis, tranexamic acid is used, and the guidelines, as Girish has pointed out, has given a excellent, strong recommendation for the use of antifibrinolytics, like tranexamic acid in cardiac surgery to reduce perioperative blood loss and transfusion requirements, which he showed in a large number of patients, and that we find it to be true in our clinical setting also. So we use tranexamic acid. That answers the question. Next question is about how to measure functioning platelets. This, I think, is directed to the second speaker. Dr. Sunil, you want to take this question, please? Or anybody else who would like to answer?
I could take the.
Yes, please. This is a very important question because several of patients are on antiplatelet agents and we do not know what is the degree of platelet inhibition. So platelet function test will be indicated in these patients. The recent version of TEG can give you the platelet function mapping directly, and also we have other devices like Verify Now, which tells us the degree of inhibition of platelets in a given patient, especially when they are on antiplatelet agents. This is especially useful in patients who are coming for.
Hello, so can you mute yourself? So now you can continue.
Yeah, especially important in patients who come for non-cardiac surgery when they have coronary stents placed and the optimal duration of antiplatelet agents to be given for that particular patient is not at over, but the surgery is time sensitive or even emergent. In that case, you need to know what is happening with platelets. So in those cases, it becomes very, very useful to know the degree of platelet inhibition. And one point I would like to mention is that if the patients are on antiplatelet agents, just because you are going to do surgery, prophylactic platelets are not administered. I think this point also has to be emphasized. Platelets must be kept ready, and if there's any bleeding, then you can give it. Otherwise, platelets are not given prophylactically. Anybody else wants to comment on this question? Next question is encourage autologous blood donation if HB is good. I think Girish has to answer this because this involves the blood conservation techniques. Do you encourage autologous blood donation if HB is good? Dr. Girish, are you there?
Yes, sir, I'm here. Sir.
So would
Yes,
you
sir,
like
if
to
the
answer
hemoglobin is good, you can advise for preoperative autologous donation, sir. But it is a very tedious process, and patients have to come and go to the hospital multiple times, multiple pricks. So patient cooperation is more important in this.
Yeah, that is true. I agree with that answer. But the other thing is we do collect blood in the intraoperative period if the hemoglobin is upwards of 14 grams, if there are no contraindications, and give it at the end of bypass, and it works out well. Somebody else is talking in the background. So it works out well. You are giving back patients all blood, so there is no complication because of the blood donation. Blood transfusion reactions, etc., are avoided, and also you're giving platelets which are contained in the. It's almost a fresh blood. It's kept at room temperature in the theater, and the platelets are still there. So it's a good way to do that. Anybody else wants to comment on this autologous blood donation? HB is good, I think.
Yeah, I think intraoperative for the patients with the tetralogy of Fallot's with the high hematocrit, we have all practiced in pediatric cardiac anesthesia practice. Adult patient, I think if Jehovah's Witness with low risk, probably you can try. We don't regularly do it because of logistical issues. Otherwise, I think, but I think there is a study which tells that there's a wastage of blood if you're really planning for 5 weeks and take one pack every week or so. There might be wastage. The blood may not go, may not be used at all. So we have to take care of that factor as well. Probably for a few weeks we can try collecting bloods and.
Actually, intraoperative autologous blood donation works out well. Some of this, it also depends on the surgeon's opinion and the perfusion is also, it's a team decision. I would like to do autologous blood transfusion, donation inside the operating room wherever there is a possibility. Now we'll go on to the next question. How many days do you want wait after erythropoietin administration? This again blood conservation technique. I think Girish has to answer this one once again.
Usually, sir, after the erythropoietin administration, if you wait for 1 month, the hemoglobin increases by 2
Right.
grams per deciliter. So once your desired hemoglobin levels are met, then that is when you know that the erythropoietin has worked.
Mhm. Yeah. There are two aspects of treating these patients, especially patients with anemia. They have significantly increased risk of blood transfusion during the surgical procedures, just because their hematocrit is already low to start with. So any bleeding inside, bleeding or even oozing will decrease the hematocrit further, and the risk of transfusion is increased in these patients. Hence, to prevent the risk of blood transfusion, it's a good idea to increase their hematocrit preoperatively if the time available is is enough for them to undergo this form of treatment. Having said that, the erythropoietin along with iron works out very well. You have to give iron supplements also, and then it works out very well, and you may achieve the target hemoglobin during a surgical procedure without having to take recourse to RBC transfusions. Anybody wants to add anything to this point?
Yeah, it's pretty well said, sir. The couple of other hot issues are in case you have a patient who's received thrombolytics and then he has to be planned for surgery. So how do we go about that? So how long to wait before taking the patient for surgery, especially if it's a misdiagnosed MI, and then it turns out to be a dissection, you need to take him for surgery. So how to go about that?
It's a different, difficult problem. Anyone would like to answer that?
So
Yeah, I
it's
think one.
depending upon, yes, sir.
Yes, come on.
So it's depending upon which anticoagulant has been taken. So
No, it's not anticoagulant, thrombolytics.
Thrombolytics.
Yeah.
It is, yeah, it's a
yeah.
difficult scenario. It has to be taken by a primary surgeon who is dealing with the the surgery, and he should explain the surgery. Apart from that, he should have a backup of blood products in the blood bank, and try to use cell savers rather than transfusing allogenic transfusion. All this will come into picture in this scenario. Anything?
Yeah, I think well said. And probably if it is a semi-emergency, not immediately done, probably if you can wait for a week or so, you have a better chance. And then I don't know whether there's any role for recombinant factor 7 or the PCCs in this kind of patient. Yeah. The advantage with the factor 7 is if the fibrinogen is adequate and the platelet count is adequate, then you have a good chance that patient may be you may be able to manage this patient, because these are the only two factors required when you have a recombinant factor 7. So you have to have adequate platelet count and good fibrinogen levels. The rest of the factors can be taken care. Yeah.
Any other point to be discussed? I think we have addressed all the chat box questions. Anybody wants to add anything?
Hello, sir. I just have a point to make.
Yes, absolutely.
Pooja here, sir.
Please.
Sir, I would recommend that everybody read the guidelines of Dr. Brolinger, so Klaus Brolinger. So he has written that A5 based cardiothoracic algorithm for bleeding management in Rotem, which we follow in Narayana. So that gives very specifically about how to go about with looking at A5 values in XTEM, FIPTEM, and the CT values, when to give tranexamic acid and fibrinogen, platelets, or PCC. So I think that algorithm makes everything in a very concise way and gives very clear idea about how to go about and manage bleeding. Also, very important thing which we usually tend to forget is hypothermia. Hypothermia
Correct,
is something we
correct.
should always look at and keep the patient warm, because once that cascade starts off with patient being hypothermic, then the bleeding, whatever products we give is never going to work. So
That
from
is
the
true. That
beginning,
is
we
true.
should always look at hypothermia and regular rotems. And what we used to do is, on just before coming off CPB, we used to send a rotem, and we could get some time to, order for platelets or cryo or FFP, and immediately start managing once we are coming off CPB. So that's also a great idea.
Yeah, that is true. I agree with that. And also, we need to consider if there's any circulating heparin, especially after bypass. As sometimes heparin rebound occurs, the easiest thing to do is to do the ACT, and then try to bring down the ACT to normal levels as far as possible. But having said that, ACT also sometimes can be fallacious. The temperature has to be maintained, the hematocrit, and the other blood gas parameters, especially in terms of acid-base balance, cardiac output, etc., must be also attended to as you're treating the bleeding in these patients.
And also, if we have a Tech6 machine with platelet works, it will be great. It will
That's
give us
what
a
I mentioned
baseline
earlier.
platelet count. Yeah, with percentage aggregation, that is what we look at, and functional
Correct,
platelet count.
correct.
That will really help us in giving, especially SDP. We can order it prior and keep it. It's any day better than RDPs.
Yes. Yes. So this question was asked, and I did reply that the recent version of TEG can get us the platelet function mapping, and then you can see whether the existing platelets are actually functional or not. Thank you. I think we are at the end of the session. We have answered all the questions which are there in the chat box. If there are any further questions, please contact us. We'll be happy to reply back to you. And with this, I would like to repeat that we have the ICA Con 2024 in Lucknow, second weekend of September, and this month end we are having the PG assembly in Delhi, GB Pant Hospital, and 24th of this month happens to be the 4th anniversary of webinars. Today is the 207th webinar, and on 24th it will be completion of 4 years of webinars on Wednesdays from the ICA. With that, I would like to thank all the participants, and special thanks to the faculty present here, Dr. Siddharth Raju, Dr. Sunil, Dr. Medha, Dr. Girish, and my panelists, Dr. Sanjay OP, Dr. Ratan Gupta, Dr. Pooja Natarajan, and all the others who are present.
Thank you so much, sir.
Thank you so
Thank you,
much.
sir. Thank
Thank
you.